Hello, all. Uh, this could be a lecture. This is the compensatory or the lecture from when I wasn't available on yesterday morning, which is Friday. I'm doing it early in the morning. So I'll be sipping coffee and likely to be disturbed by some kind of animal. So it may come in sections. And I'll show you where we left off and we'll get started right there. Here we go. So we're basically doing gastrointestinal and digestive system physiology, and it starts here. So, what does the stomach do? Breaks down the food. Basically, it's a giant mixing bag. That's the anatomy of it. The rugae, the ridges, the three layers with the oblique layer moving it over and back, over and back. And the eventual end product is something called chyme, as you can see here, CHYME, that has to do with uh, really processing everything, and you get this sort of white, kind of curdy, mushy kind of stuff that's really been battered down by a combination of a variety of digestive juices, highlighted by hydrochloric acid and two kinds of enzymes. One that's mostly the first proteolytic enzyme, pepsin, we talked about earlier, and also some additional lipase. So we're continuing the breakdown process of fats. And you can see that the milk protein is in infants, they have something called renin, which is, even though it looks the same, has an additional N. I always misspell it on tests. That's the one that is involved in the renin-angiotensin mechanism. And the casein is like that. And interestingly, they don't, as you'll see down the road, they don't have the lactase early on. So infants, it's there's a transition period because almost all infants are born lactose intolerant. There's certain kinds of milk they can't drink, typically cow's milk early on. The key issue with regard to problems is when we do, it's not really designed for absorption. So when we absorb things, they have to be either liquid soluble or they have to be agents that seem to have the capability of disturbing the boundary and penetrating it. That's where aspirins, non-steroidal anti-inflammatories, caffeine, substances that have hidden caffeine, like chocolate or tea or coffee, certainly do, and alcohol particularly. All this combination there's a number of things that are gastrointestinally difficult. And for someone like me, that was probably the underlying thing that caused a lot of those gastric ulcers. I mean, I'm eating pills for headaches like it's going out of style. Along with a bunch of other stuff I shouldn't have been doing, in addition to smoking, all of that manifested itself into a lot of problems. Just to be clear, this was in and of itself, it probably wouldn't have been enough since I didn't drink almost at all during this period of time. But I had a small structural alteration. It was like a little hidden flap just at the start of the duodenum, which facilitated things backing up, and that added to the problem on top of it. The essential function is intrinsic factor, and it's become less essential today because we can give B12 by a variety of methods, usually by injection. And without B12, you develop a very famous anemia called pernicious anemia. I probably have a touch of that. Perhaps because of the limitation of that, or maybe I don't absorb B12 as well as I should. But at least it's remedied by B12 supplements for me most of the time. So as you can see, there's a lot of gastric juices. 3 liters is a lot. I mean, a better part of a gallon. That's there. And you can see what goes, the vagus and the sympathetic upticks and downticks that are associated with it. And the key issue of, remember those G cells, those enteroendocrine cells, is the gastrin. And the gastrin stimulates stomach activity as well as hydrochloric acid secretions. And once we start to see the onset of something called secretin, secretin, which is, and we probably won't get to that today, it's when the food enters the small intestine. At that point, we develop, it basically terminates the aspect, or they call it the anti-gastrin, but it basically reverses or slows down the activity of the gastrin. That's there. Classically, they describe, I'm going to be attacked by a white cat. Gastric secretions are broken down into these different phases. I don't do them. When you start thinking about or smell food, that's the cephalic phase. When it gets into the stomach, gastric phase, we get into the intestines, the intestinal phase. The gastric phase is sort of critical for us here. It takes a fair amount of time. And that amount of time, things don't go through that fast. It's true that when people will tell you about like alcohol, and particularly with carbonation, so certain things like champagne, a carbonated or a sparkling wine, and say, oh, that goes to my head. It does. That has a much more rapid kind of an absorption. There's certain things that do that. And an empty stomach, really, if you enjoy a drink or a beer or something like that, that's great. Careful on an empty stomach because it increases the degree of irritation and it's a more rapid degree of onset. And you can see what it does. It stretch receptors, both initiate the enteric reflexes and the so-called long reflexes, chemicals, partially digested proteins, caffeine, low acidity activate those gastrin cells. So when you put something in there and it offsets the normally acid environment, basically it's a signal that says, hey, make G cells to be active. And so the gastrin initiates the hydrochloric acid, activates that particular enzyme to be secreted in both the hydrochloric acid and the pepsin. And as you can see, it stimulates a variety of things, and then it co-stimulates. Sort of think of it this way. The gastrin is released first by that, and then the enteroendocrine cells themselves are induced by the gastrin to release histamine. And so when you ingest something, most things, it activates more gastrin because what you're doing is you're increasing the pH. You're creating you're offsetting or neutralizing some of the inherent acidity of the stomach. Acidity is an interesting thing. A lot of people, if you're like us, we're constantly looking at let's say traditional remedies for different problems, quote unquote medical remedies. A lot of people are taking tablets with ACV, that's apple cider vinegar, because to some extent we think that that irregularities in acidity, sometimes your stomach inherently has too little acid and it manifests itself like acid indigestion, but it really isn't. So sometimes a lack of a thing can be as problematic. I induce that in myself by eating all those Prilosec and blocking that proton pump mechanism. And to some extent, that really, you lost a lot of the protective nature of acidity because the acid is at your weapon against bacteria, viruses that are fragile enough to be attacked by the acidity, other issues, toxins, and things like that. That's the beauty of the stomach, is the acid that's in there, as long as it doesn't get where it shouldn't be and there's a sufficient amount of it. So low pH, acidity between meals, during digestion, negative feedback. The more protein, the more hydrochloric acid secreted, declines pH, which eventually, okay, when you get to a certain level, then the gastrin secretion starts to, so you can see the balance. I think the more acidity that's produced, eventually will slow down the gastrin. The less acidity, because typically means you've ingested something, will increase the gastrin. So it's really, there's a fine tuning. Most of us don't have to worry about that. Most of us don't have to worry about that. We eat relatively normally. If you go out and indulge or have a few drinks and things like that, maybe you feel it a little bit in the morning or whenever it's happening, and you take it easy afterwards. But you will find in life as you get older that excesses of anything are where problems are, or if you don't give yourself a sufficient amount of recovery time. So much for the sermon on we call it the temperance lecture. I had people came, many years ago, early days in practice, where a lady came in who was the wife of a patient of mine, who just drank too much. And, was trying to get me, because of all the problems he was having, to give him a temperance lecture. It didn't work out. basically telling them to stop drinking. Boy, that was a big fight. So sometimes it's just hard to do. Okay. The intestinal phase, okay, as the food starts to enter those, and it's little tiny squirts, it's so acidic that as it shoots through what we call that pyloric sphincter, that little opening. We're talking a half teaspoon or so, a couple of milliliters at a time of this highly acidic. It's rapidly neutralized, but there's enough uh, osmolarity to it. It's so high in that and so high in acidity, it's what triggers this. So, as you can see, entering the small intestine, a brief release of intestinal gastrin. Okay, and what that does, this little signal, even though it theoretically it would be, you would rather have it start to neutralize it, the first thing it's got to do is try to empty the stomach. So there's a certain degree of encouragement. It's very, very brief because as soon as it gets a little farther along, then it starts to release the secretin, okay, and the stretching begins to slow down the process because basically it's almost like saying, hey, don't load us too fast because we don't have enough room right away. We've got to move this stuff along. So everything has to move along segmentally and in the proper proportions to prevent backup. And I say it 1,000 times every year, and you'll see it in a lot of systems. Ultimately, it's a plumbing problem. If it backs up and there's still a push to push it along, then we have a problem. Okay. The factors that inhibit the duodenum are within the duodenum: the distension in the chyme entry, the acidity, the typically fatty nature, because we start to pre-process the fats, the hypertonicity, the osmolarity of it. Okay, these inhibitory effects from being overwhelmed because of all that stuff, particularly the acidity. And it's achieved by two ways. There's a certain thing called an enterogastric reflex, and the hormones, which are called entero. We really use the term entero versus gastro. Entero really speaks to being in the intestine. Okay, so you can see that there. The enterogastric reflex, the duodenum itself, and it's a very short loop. It's about 10 to 12 inches long, and it comes immediately, and it's the most important area. And you've heard me say it before, and you'll hear me say it again. It's really the pivot point for the fact that your gastrointestinal system works, because within it is the single most important area. And you might recall, or for those that didn't have it, that's what we used to call the common bile duct. Okay, now they have the hepatopancreatic ampulla. Fine, they had to give it a new name. But the reality is that's the depositing point for all of the chemicals that come from the liver and from the pancreas that mix and basically achieve what you and I call digestion and absorption. Without that area, your intestines, which are essential to you being alive effectively, don't really work. So in the absence of that common bile duct, your life changes. And you effectively have to do a procedure that involves creating an alternate passageway for nutrients. You really can't eat anymore. You basically have to have put in appropriately pre-digested food so that it can undergo some degree of limited absorption if it's possible. It would be just horrible. And I unfortunately was facing this immediately before my second major gastrosurgery. The first thing that they had to do when they saw they had to redo the surgery, and here I was bleeding internally all over the place and just a mess. The first thing they had to do was to do a CT scan with contrast to make sure I had that the blockage did not preclude the functionality of the common bile duct. The common bile duct was sort of like sitting there in space, still attached to a limb of the duodenum, and still able to provide pancreatic and hepatic and hepatic secretion. So it still worked. Food didn't flow through it per se, but it still kind of worked. It's fascinating. So just for that, the reflex there, the enteric nervous system and the acidity triggers that to slows things down. The sympathetic nervous system and the vagus or the long reflexes. So there's impact from those. And then the enterogastrones, the hormones, secretin and cholecystokinin. They have multiple effects. The cholecystokinin is basically telling your liver to release. Cholecysto means gallbladder. Squeeze it, and assuming it's there, if not, it'll just work on the liver itself, and release bile along with all the interesting chemicals in bile to basically take care of the fats, to start to break them down appropriately. And secretin, which does everything else, slows down the slows down the gastrin, stimulates the pancreas for all these what we call zymogens, pancreatic juices, including which are highly alkaline, etc. We'll delve into all of those. So you can see all this stuff. And if you want to look at this table, because certainly not going to go through it, but it gives you an idea of what ticks it up and what ticks it down. So you have stimulatory events on one side and inhibitory events on the other side. And then and I like it when books give you these nice tables for you to look at and say, here's what cholecystokinin does. So in the stomach, it slows down the stomach. In the liver and pancreas, it makes it secrete the things it's supposed to deliver, rather, easy for me to say, eventually to small intestine, to the pancreas. Then it also, pancreatic juices, which are filled with those zymogens. So first it potentiates the liver and the pancreas, then it actually works directly on the pancreas, and the same true for the gallbladder. And if the gallbladder is not there, it'll still work. And it relaxes that bile duct, the hepatopancreatic sphincter, which controls the opening to allow all that stuff to get in. So here you see gastric and glucose-dependent insulinotropic peptide, also known as, in the old days, as gastric inhibitory peptide. Pardon me. Fatty chyme gets in there, works on the stomach and the pancreas to slow down minorly hydrochloric acid. Okay, we're going to stop the stomach, but most importantly, insulin. Again, when we're eating, the design factor is to use insulin because we're inevitably going to have glucose or glucose-like products that we can throw through the Krebs cycle and do our thing with it. Gastrin, multiple activities as you can see. And that's in the stomach. Hydrochloric acid does help the stomach to start to empty, contracting the muscles. Interestingly, the ileocecal valve, it's almost like saying at the end of the small intestine, let's move some stuff out of the small into the large intestine. So at that point, we're going to be within a couple of hours filling up the small intestine again. And when you do this, and many people notice this, when they eat something, sometimes they'll get that urge to have a bowel movement, have to go to the bathroom. Okay. And maybe it'll pass, but depending on the situation, it may or may not. Histamine, again, parietal cells increase the release of hydrochloric acid. More gastrin itself within the intestine plays a role as well with other glandular structures and motility. It's just as though to complete this stomach process. Fascinating. So it's a really neat little chart. You can take a look at that, and I can't go through all of these again, but you can read them as well as I do. So go back and look at them. Serotonin, a stimulant in this case, contracting it. Motilin, migrating motor complexes. They're kind of interesting. It's sort of like moving things along. Okay. And you can see, and that some of that is, you notice where it says periodic release and fasting, stimulus for production. We're seeing a lot of these diets and for these intermittent fasting. This is kind of where that comes from. I haven't looked into it that deeply, but you understand that fasting has certain effects which are somewhat beneficial in a lot of things. So just check this stuff out. What happens? This is the proton pump. Classic example. The cat wants to come back in. So the parietal cells acquire the hydrogen ion from carbonic acid, and we went through that. Okay, and you can see it's a potassium proton pump, ATPase. That's what the proton pump is. As the proton is pumped into the lumen, bicarbonate is exported back to the blood by a chloride and bicarbonate antiporter. And so here we get, just like we talked a little bit about chloride shift in blood, You begin to see the resulting increase of bicarbonate in the blood because it's effectively replacing the negative particle of chloride. So it's called an alkaline tide. And that has some impact. Again, that alkaline tide, you'll see that it reverses itself. The alkalinity is useful in other areas. Okay. And the chloride is pumped out to the lumen to join with the proton to form hydrochloric acid. And they're showing you this. And again, it's through the magic of carbonic anhydrase that's located within these parietal cells. So here's the parietal cells and the pumps that are there. So effectively, bicarbonate is going into the bloodstream in the capillaries at that area, and the chloride is being brought in to create that hydrochloric acid. So we see the pumping mechanism that's there. It stretches to accommodate incoming food. Okay. And until you get to about 1.5 liters of food, that's quite a bit. That's 1.5 quart. You have reflexes that allow it to relax. The smooth muscles, interestingly, uh, can stretch without increasing tension or contractions, as you can see here. They're designed to stretch. And then once they empty, they have enough inherent elasticity in the structures to return to their regular thing. So if you're filling it sufficiently slowly, that's the sort of the watchword. Whenever you do something rapidly with regard to this, eating a great deal in a very short period of time, you overwhelm this, and then you get reflex spasms and sometimes vomiting. Okay. And you can see the peristaltic waves. There's an inherent rhythm. In the old days, we had to memorize the so-called pacemaker cells that were there, and they really are a kind of pacemaker cell. The interstitial cells of Cahal, okay, and gap junctions, of course, as you might expect, playing a role in sending the signals all the way around. And some of this force can be increased, and the ability to distend by gastrin. So gastrin sort of makes the party work. As it really gets busy with it, think of it, you're churning, and now you're pushing that toward a funnel-like structure, which is what the pylorus is. So as you can see, 30 milliliters of chyme produced is either approximately 1/2 teaspoon, that's 3 mils, and the rest is forced backward. Okay. And so only if it's in the liquid and very tiny particle phase can it get through. So it's really the design is such, it's almost like compacting it and finally getting through. It's like, here we go, cooking analogies. It's like a lot of times you put something in a big strainer and you'll see a chef, they'll take a ladle and they'll sort of push it through the strainer just to get everything through there, because it has to be sort of mushed down a little bit more to make the particles smaller to get through. And then if something can't get through, you can just clean it out and start again. And they're just showing it to you here. Okay. Duodenum prevents the overfilling by controlling that, again, with receptors and reflexes and the subtle effects of these enterogastrones, the secretin and the cholecystokinin. 4 hours, but increases in fatty chyme can increase the time to 6 hours. So a fattier meal will stay in longer. This is the kind of stuff, when they look at stomach contents forensically for cause of death and time of death, that are of some interest, because certain things in the stomach break down slower than other things. You know, if you go out and get a donut, it's going to be gone really fast. Relatively simple carbohydrates take very little time to break down. If you have a salad with lots of broccoli and cauliflower and those kind of like cruciferous fat, they take a long time to break down. Okay, vegetables take a long time to break down because there's so much in there. There's a lot of cellulose that has to be broken down before you can address the stored starches that are in there. So carb-rich chyme moves through quickly. Extreme stretching, various kinds of irritants. Look, vomiting is reflex protection. Bacterial toxins, excessive and rapid alcohol. When it comes to alcohol, if somebody who's inclined to drink for a long period of time, okay, drink slowly. A friend of mine who I lost contact with many years ago is now gone. He's the best long range drinker I've ever seen. He started. He's a podiatrist like I was. We were fast friends in school, and he learned in the Navy because he was a Navy vet before he started school. I said, "How can you drink that much?" He goes, "I just take my time." He'd be drinking beer from 10 o'clock in the morning and never stop. God bless. God bless. Spicy foods, certain medications, etc. I think we're pretty familiar with it. And the big problem is you're losing electrolytes, and particularly you're impacting the acid-base balance and fluids. And that's a kind of, we'll call that metabolic alkalosis. And you can get that a variety of ways. People overindulge and gobble tons and tons of things like Tums and Rolaids and various agents designed to deal with indigestion, can even create that themselves. Perhaps more common in the very old and very young this way. And that kind of leaves us with our next topic. And I think I'll start that next time we meet with the liver, gallbladder, and pancreas. Okay, because and just quickly, you can see what they do here. The liver, it's about bile, and bile is because fats, we don't break their bonds, we just have to separate the particles. And that's what emulsifiers do. They separate the fats into individual components. Remember, it's not a peptide bond. It's totally different kind of a thing. It's not a chemical bond that has to be broken down. The gallbladder is really a storage vesicle. It's just like the overflow tank in your car for antifreeze. And the pancreas is another one of those wonderful essential areas that all those enzymes and bicarbonate that are so critical for that. And this is the anatomical part, and we're going to skip. It's there. And the only point I would say to you in the anatomy, which certainly is not part of this unit to know, is the entry level of the hepatic portal vein draining, and that's again the term we use for veins, all of where food is absorbed, stomach, small and large intestine, mostly small, and then sort of what I would call percolating its way throughout the liver, and then eventually forming hepatic veins as it exits the liver more superiorly and enters in two areas into the inferior vena cava after the blood from the bowel effectively has been processed, and it continually making bile going out the other way. There's three things that enter, three things that are penetrate this hilar area called the portal hepatis or hepatic portal. You have the hepatic artery for nutrition and energy for the cells, the hepatic portal vein, which is the processing material. Those are incomings, and going out, you have the bile duct, in this case called the common hepatic duct. So it's the duct, and this is exiting, overflowing into here, some degree of processing, but it's non-essential. And then a series of ducts anatomically to bring you. And it's all because of this hexagonal structure that you might recall called lobules, tiny lobes of the liver. And they're all identical. Doesn't matter where they are in the liver, they're identical. And effectively, these hexagonal structures have mounds and mounds of these plate-like identical liver cells, and the blood just kind of goes, think of it just like filtering through it, and it does so, it's processing, and it's going sort of from outside to inside, running across, being processed and collected by a central vein that eventually leads into the hepatic vein, the exit point of the blood. So again, portal systems, capillary bed to a vein, to another capillary bed. So the capillary bed that's coming from the bowel into the portal vein, into the capillary bed, which are the liver capillaries, which are the sinusoidal capillaries, and then collected by another vein, the hepatic vein. And so artery in, hepatic portal vein in, bile duct out. But going back kind of the way the hepatic portal vein came in. They all look like this exactly microscopically. So you're going from each of these points in, percolating, as I say, through all these little nooks and crannies, if you want to think of it that way, sort of like a glorified English muffin, and then centrally being collected in that central vein. Love this. And and you might recall, I told you, when you biopsy a liver, you're looking for irregularities in this structure. When this is not a nice, relatively nice looking hexagonal structure, when it's contracted, that's scarring. And that scarring comes from hepatitis. That's what they're looking for, which you would expect to see in a liver biopsy. So if someone has hepatitis for whatever cause, alcoholic, perhaps the most common, infectious, A, B, C, the most common players, although there are more, and you begin to look for asymmetry in this, and the asymmetry points to the fact that there's scar tissue, and that's bad, very bad. So that's what it is. Lots of macrophages in there. Those are those antigen-presenting cells, because again, this is not only there as the debris and old red blood cells that can take the place of the spleen, because the spleen is non-essential. Okay. And again, we have a lot, and we're still encountering immunological things that are in there, potentially invaders or toxins. And I love that illustration because it really defines all this sort of like, imagine the blood just going through back and forth easily and doing all of its thing. They make about, as you can see, per day, not quite a liter of bile, process all that good stuff. It's fat storage for fat-soluble vitamins. Glucose is one of the two areas where we can store glycogen. The other is obviously in skeletal muscle. Plasma proteins, the absence of the liver doesn't leave you have the albumin, the globulin. So it's so critical and vital. Detoxing mostly from proteins, the deaminated the deanimation of amino acids leads ammonia. Two ammonias mix with carbon dioxide, and voila, we get something that's about 100 times less toxic than ammonia. Urea, which we have a greater tolerance for, but we do have to get rid of most of it. And at the same time, the bile is making, mostly from cholesterol and other factors, bile salts. And it combines with the bilirubin, the breakdown from heme, and eventually that has to be excreted. So the bile salts, to some extent, or a large extent, are recycled. But the bilirubin is gotten rid of in either urobilinogen or stercobilin that colors the urine and the feces. And so all of these things are part of it. Cholesterol, triglycerides, phospholipids, electrolytes are all within there. So we're getting rid of some of that stuff and recycling some of the stuff that is there. And the recycling of it, I got into this, I might as well finish. It's famous, it's called the enterohepatic circulation. And it conserves bile salts. About 95% of them. The original anti-cholesterol drugs, when people had high cholesterols, tried to interact with this mechanism and prevent the recycling, the reabsorption, and it put tremendous strain on the liver. And so I'm not sure. I'll have to look up how the one that we see everybody on now is called atorvastatin. And I didn't particularly like taking it. It gave me a headache, and my cholesterol numbers weren't that bad. My former physician who retired, my family doc, wanted me to take it. I kind of like it. He basically said that theoretically it could reduce your risk of heart attack and stroke, to some degree. He felt was significantly, and I don't know if that's necessarily true, but I'd heard more bad about it than good about it. So Lipitor is a trade name, and if you've got somebody in your orbit who's my age, they're probably taking Lipitor. Okay. And so what happens, they go all the way in the small intestine to the last part, the ileum, and then they're brought back by the hepatic portal blood, and they basically are recycled 95% each time. And they have an elaborate chart that shows you how it produced here in the area at the common bile duct. They go all the way, and they play a pivotal role, as we'll get into with what they do with fats. And then eventually, here you can see this is the ileum, the ileocecal valve. They're reabsorbed in the hepatic portal system and returned and recycled. So let's stop there, and I'll talk a little bit about these kinds of things, cirrhosis and hypertension, etc. Next time we meet on Monday, we're going to spend a lot of time with the digestive, and hopefully, and we should be able to finish it between lecture and lab. The lab component will be most likely just continuation of lecture. I want to get that out of the way to free up time for the presentations in the last couple of weeks. So I'm hoping to get all of this, the vast majority of the lecture material done before Easter. Okay. So we have this week and effectively we have this week and next week. So I think I can get, if I can get through digestive and urinary, and we certainly should in the next couple of weeks, and even start the reproductive physiology, we should be in great shape. All right. Thank you very much. Say goodbye and goodbye.